Hi, I'm Dr. James C. Wittig. I'm an orthopedic oncologist and sarcoma surgeon. Today's discussion or lecture is going to be on the various different types of osteosarcomas. Osteosarcomas are malignant bone-forming tumors. They are tumors that arise from the bone and actually produce bone themselves, produce immature bone, and that's how they get their name, osteosarcoma. For more information on musculoskeletal tumors and sarcomas, please visit my website at www.tumorsurgery.org. An osteosarcoma is a cancerous spindle cell tumor or sarcoma that is derived from a mesenchymal stem cell precursor that produce immature woven bone or osteoid. So the key to diagnosing an osteosarcoma is that it produces immature woven bone or osteoid, and it's cancerous in appearance. The cells are cancerous. It is a bone-producing sarcoma, meaning that it has the ability to metastasize. It is not benign. These are all your different types of osteosarcomas. It's important that you actually memorize this list, or the main portions of the list. Intramedullary, juxtacortical, intracortical, secondary, and osteosarcoma with specific syndromes are all your different main categories of osteosarcomas. Your intramedullary osteosarcomas are the most common type, and out of them, your conventional osteosarcoma is the most common type of osteosarcoma that presents in usually children and adolescents between the ages of 10 and 20 years of age. Probably constitutes about 80% of all osteosarcomas. You also have telangiectatic and well-differentiated intraosseous or low-grade intraosseous osteosarcomas. There is also a small cell osteosarcoma that's an intramedullary type also. Now you can see under your conventional types of osteosarcomas, there's different subtypes, and basically osteosarcomas can have different types of tissue, not only bone within them, but can have a lot of cartilaginous tissue, can have fibrous type tissue, can have tissue that looks like a malignant fibrous histiocytoma or undifferentiated pleomorphic sarcoma. Can also have a lot of giant cells within it. It can be confused with a giant cell tumor. So there are a lot of different tissues that can be seen in an osteosarcoma, but a conventional osteosarcoma, by definition, has malignant appearing spindle cells. In other words, they're large cells, hyperchromatic, they're crowded, they're extensive pleomorphism, mitotic figures, fast growing, a lot of anaplasia, that are producing immature woven bone. This is the most common osteosarcoma to affect children and adolescents. You have your juxtacortical osteosarcomas, which lie on the surface of the bone or develop from the surface. Parosteal osteosarcoma develops from the outer layer of the periosteum. Periosteal osteosarcoma arises from the inner layer of the periosteum. And then there's high-grade surface osteosarcomas. Intracortical osteosarcomas are extremely rare. And then you have secondary types of osteosarcomas that develop in an older age population. Patients with Paget's disease may be predisposed to an osteosarcoma. Patients who have been treated with radiation can develop osteosarcomas. Bone infarcts and fibrous dysplasia, metallic implants, and chronic osteomyelitis can also give rise or be predisposing to an osteosarcoma. Then there are a few syndromes that can be associated with osteosarcoma. There can be some familial cases, very rare. Retinoblastoma, patients with retinoblastoma are predisposed to osteosarcomas. Rothman-Thompson syndrome, there's such a thing as multifocal osteosarcomas, and osteogenesis imperfecta. Those patients are also predisposed to having osteosarcomas. So some generalities about osteosarcomas. All osteosarcomas are high-grade osteosarcomas except the following: well-differentiated intraosseous or low-grade intraosseous and parosteal osteosarcoma. They are low-grade osteosarcomas and are usually just treated with surgery. They're slower growing tumors and they do not respond to chemotherapy, and they are almost all cured with surgery alone. Your conventional, your high-grade surface, your telangiectatic, your periosteal osteosarcomas are all treated as though they are high-grade tumors. They receive chemotherapy before surgery, then postoperative chemotherapy. Chemotherapy before surgery is referred to as neoadjuvant chemotherapy, and chemotherapy after surgery is referred to as adjuvant chemotherapy. Intracortical osteosarcoma, nobody really knows the exact way to treat that because it's extremely rare, but more than likely it would be treated, if histologically it looks like a high-grade tumor, it would be treated as a high-grade tumor. Technically, periosteal osteosarcoma is a chondroblastic type tumor. It is made primarily of cartilage that demonstrates areas where there's spindle cell bone production, and it occurs on the surface of the bone. It's an intermediate grade tumor, but it's treated as though it's a high-grade tumor. Parosteal osteosarcoma is a fibroblastic type of tumor that's producing bone. There's extensive amount of fibrous appearing tissue with bone production. Just some general information about osteosarcomas. Osteosarcoma is the second most common primary malignant tumor of bone. The first most common primary malignant tumor of bone is multiple myeloma. Osteosarcoma is the most common primary cancer of bone in children and adolescents, or primary sarcoma of bone in children and adolescents. It constitutes 15% of all biopsied primary bone tumors, and there are about approximately 600 to 700 new cases of osteosarcoma in the United States per year. Clinically, patients usually present with mild pain and swelling for weeks to months. There's usually there may be associated with a high serum alkaline phosphatase level, and there are two peak age groups. Most commonly, osteosarcoma occurs in the 15 to 25 year age group. It can also occur over 50 years of age, but when it does, it's usually secondary to an underlying predisposing condition such as radiation or Paget's disease. Most common sites for a conventional osteosarcoma, which is our most common type of osteosarcoma, is the distal femur, followed by the proximal tibia, followed by the proximal humerus. 90% of osteosarcomas or conventional osteosarcomas arise from the metaphysis, and 10% of them arise from the diaphysis. And this is contrary to Ewing sarcoma, where the majority arise from the metadiaphysis or diaphysis. Most patients with conventional osteosarcoma present with stage 2B tumors. The most common sites of metastases are to the lungs, the bones, and the liver. Liver is the third most common site. It actually rarely occurs. Approximately 15 to 20% of patients present with detectable metastases to the lungs. So majority of patients do not present with metastatic disease, but about 15 to 20% present with overt metastases to the lungs. Skip metastases can occur within the same bone. Skip metastasis occurs within the same bone or across the joint in an adjacent bone. They occur through the intraosseous venous system within the bone or through the transarticular venous system. And when a skip metastasis is identified, it confers a poor prognosis. Patients rarely survive who have a skip metastasis. So skip metastasis would be, for instance, a patient having a distal femur osteosarcoma and having a small metastasis in the intertrochanteric area, and no other areas of metastases throughout the body, and hence it's theoretically this travels through the venous system intraosseously and forms a metastasis at the proximal end. It's a very poor prognostic sign. Here's an example of an osteosarcoma with a skip metastasis. Here's an MRI, distal femur osteosarcoma. This is what a normal femur should look like on this side. And here is a skip metastasis in the femoral neck. So to treat this patient, if you're going to treat them surgically, you would have to remove the entire femur. Conventional osteosarcomas radiographically present as permeative lesions, meaning you cannot make out the borders of the tumor on an X-ray. The lesions themselves can be mixed sclerotic and lytic, which is the most common radiographic presentation, can be purely osteoblastic or purely lytic. This is an example of an osteosarcoma, the proximal humerus, with mixed lysis and sclerosis. It's a permeative lesion. You can't make out the borders or where the tumor begins and ends. It's metaphyseal in origin. There's mixed lysis and sclerosis. There's these fluffy cloud-like densities within it, indicative of bone production or immature bone production, and calcified osteoid. And this is the most common radiographic presentation. 95% of tumors of osteosarcomas or conventional osteosarcomas present also with an extra osseous component, so they protrude from the bone. Here's an example of almost a purely lytic osteosarcoma, the proximal humerus. Again, permeative lesion, somewhat moth-eaten down here. It arises in the metaphysis. There's cortical destruction, and it extends down toward the diaphysis, but you really do not see much ossification within it. And here's an example of a very blastic osteosarcoma. There's an extensive amount of calcification and bone production in this tumor. It's metaphyseal in origin, it's permeative, and it demonstrates heavily calcified osteoid. So conventional osteosarcoma can present in any of those three ways. Here's another X-ray of a conventional osteosarcoma of the distal femur. The tumor is permeative in nature with mixed lysis and sclerosis. There's ossification. The tumor has extended into the soft tissues. There's somewhat of a hair-on-end appearance here, but there's this fluffy cloud-like density in the soft tissues, indicative of immature bone formation and calcified osteoid. So there's ossification in the soft tissue component. There's Codman's triangles, which are very worrisome. The periosteum here has gotten lifted at the periphery, directly overlying the soft tissue mass. It's been destroyed, but at the periphery it's been lifted and it's had an opportunity to react, and it forms a Codman's triangle on both sides here. So this is classic for a distal femur osteosarcoma. This is a patient with an open growth plate who's skeletally immature. There's another osteosarcoma of the distal femur, and you should notice metaphyseal origin, permeative, you can't make out the borders of the lesion, soft tissue mass with these cloud-like densities in it, indicative of ossification, which should help you place that into it's a malignant appearing tumor that's producing bone. So you should be able to put that into likely a category of osteosarcoma. There's also Codman's triangle down here, which is a worrisome feature. It's an osteosarcoma of the proximal tibia. Again, a permeative lesion arising eccentrically in the metaphysis. There's ossification, there's mixed lysis and sclerosis, and it extends into the soft tissues. There's a hair-on-end periosteal reaction and some ossification in the soft tissue component. This is an X-ray of a large osteosarcoma of the proximal femur with a heavily ossified soft tissue component. Again, a permeative lesion that's producing bone, a malignant appearing bone tumor that's producing bone. Immediately you should think that this is an osteosarcoma. Here's a rare presentation for an osteosarcoma. About 10% of osteosarcomas arise from the diaphysis. This is a permeative lesion, hence you should think that this is a malignancy, and it's got a soft tissue component to it with ossification in the soft tissue component. This ossification should lead you in the direction of thinking that this is an osteosarcoma. Pathologic fracture is present in about 10% of cases of osteosarcomas. So about 10% of patients present with actually a pathological fracture. This is the microscopic pathology of a conventional osteosarcoma. It is a high-grade anaplastic tumor. So what does that mean? High grade means rapidly dividing. It means that you're going to see a lot of hypercellularity, a lot of cellular pleomorphism. You're going to see a lot of mitotic figures and abnormal mitotic figures. The cells are going to be different sizes and shapes. They're going to be crowded. They're not going to be organized in an organized manner. They're going to be organized haphazardly and crowded and bunched together. And that's what you can see here. These nuclei are huge. The cells are almost all nucleus and no cytoplasm. The cells are crowded together. They're arranged haphazardly. There's probably some mitotic figures here, and it's a rapidly dividing crowded cell. It's very hypercellular. And for an osteosarcoma, osteosarcomas produce immature woven bone or osteoid, and you can see this pink lace-like substance that's laid down in between all the cells and being produced by the cells. It's not being laid down or being made into trabeculae with nice osteoblasts lining the trabeculae like in an osteoid osteoma or osteoblastoma. It's lace-like and laid down in between all the cells. There's no osteoblastic rimming. The osteoid actually may or may not mineralize. The degree of mineralization determines how well it shows on an X-ray. So if it's not well mineralized, it may be purely lytic. If it's very heavily mineralized, it may be purely blastic. Other elements such as cartilage, fibrous tissue, small round blue cells, giant cells, and telangiectatic changes can occur with this type of tumor. So you could find different areas that look slightly differently, but the majority of a conventional osteosarcoma should have an appearance similar to this. And showing you a closer view, and you're looking at the pink-like osteoid and all of the large hyperchromatic spindle cells with large nuclei. Nuclear pleomorphism, cells are crowded, there's no trabeculae, and the osteoid is being laid down in between the cells. All features of malignancy. The treatment for a conventional osteosarcoma consists of preoperative or induction or neoadjuvant chemotherapy, followed by surgery, followed by postoperative chemotherapy. The standard preoperative chemotherapy regimen includes adriamycin, which is also called doxorubicin, cisplatin or cisplatinum, and high-dose methotrexate. These are the three agents that are used most commonly in the most common treatment regimen for conventional osteosarcomas. It's important for you to know that doxorubicin can cause cardiotoxicity. In some regimens, ifosfamide and etoposide has been added, particularly in the Italian literature. They've had some success combining these drugs with cisplatin, adriamycin, and high-dose methotrexate. Typically, you get 2 to 3 cycles. Each cycle runs approximately a month, where you get a dose of adriamycin and cisplatin, followed 2 weeks later by 2 doses of high-dose methotrexate, each separated usually by approximately a week. The blood counts recuperate, and that constitutes 1 cycle, and then another cycle is given. So typically you give 2 to 3 cycles, then have surgery. In terms of surgery, most patients are capable of undergoing limb salvage surgery or wide surgical resection and reconstruction. Approximately 5% of patients require amputations for either recurrences or tumors that are been heavily irradiated, or tumors that have not responded to chemotherapy, or tumors that are extremely massive in size. After surgery is performed, the specimen is analyzed, and it's determined how much of the tumor has been affected by the chemotherapy or killed with the chemotherapy. If greater than 90% of that tumor is dead, that correlates with a very good prognosis, so perhaps an 85% 5-year survival. If less than 90% of it is dead, then that correlates with a 65% 5-year survival, whether there's 5% of it dead, or there's 65% of it dead, or 70% of it dead. Some centers use 90% as the number, and other centers use 99%, or use a type 1 response where there's virtually no detectable tumor. And after surgery, postoperative chemotherapy is given for approximately 4 cycles. So a total of approximately 6 cycles is given. This is an X-ray of an osteosarcoma of the proximal humerus before and after preoperative chemotherapy, demonstrating intense ossification of the tumor, which is indicative of a good response to preoperative chemotherapy. So here's the pre-chemo X-ray, and here's the post-chemo but pre-surgery X-ray, and you can see how much of the tumor ossified. When that happens, when a person is given chemotherapy, that is indicative of a good response, or greater than 90% of the tumor being killed. And that confers a good prognosis, and it actually makes the surgery much easier, and you're able to save more soft tissue for reconstruction. An estimate of the response to preoperative chemotherapy occurs when the specimen is analyzed by the pathologist. This estimate helps predict prognosis. A good response, usually greater than 90% of tumor killed, has been correlated with approximately an 85 to 90% cure rate. Prognosis of conventional osteosarcoma. Localized non-metastatic osteosarcoma, that means when the patient presents, the tumor appears localized and there's no evidence of overt metastases, has overall a 65% 5-year survival. Good responders are patients who've had approximately 90% tumor necrosis or more in their specimen, have approximately a 90% chance of being cured, or 90% 5-year survival rate. There is no difference in survival rates whether a limb-sparing procedure or an amputation is performed. Patients who present with or develop metastases to the lungs have a poor prognosis, approximately a 15% 5-year survival if pulmonary mets can be resected. Patients with bone metastases have a dismal prognosis, virtually a 0% cure rate. Skip metastases also confer a poor prognosis and very close to a 0% cure rate. Changing the chemotherapy regimen postoperatively for patients who have not had a good response to the preoperative chemotherapy regimen has not been shown to change prognosis as of 2000, actually now it would be 2014. Okay, the next entity we're going to talk about is telangiectatic osteosarcoma. It is a type of intramedullary osteosarcoma, and it's a variant of intramedullary osteosarcoma. It accounts for 3% of osteosarcomas. It's extremely lytic on X-rays. It's almost purely lytic. There's very little osteoid production. It consists of cystic spaces filled with blood that are separated by thin septa. There are fluid levels on MRI, and cystic spaces filled with hemorrhagic material. ABC-like changes can sometimes lead to a misdiagnosis on X-rays, and the tumor may be misinterpreted as being a benign ABC. Here's an X-ray of a telangiectatic osteosarcoma of the proximal tibia. A large lytic lesion in the proximal tibia. It's very permeative in nature. You really can't make out exactly where this tumor starts and ends. There's some sclerotic or ossified areas over here. It may transgress the growth plate. The most worrisome feature here is a Codman's triangle. That should draw your attention to this being malignant, most of all. And there appears to be a soft tissue component of the tumor. Here's a CAT scan. There was no ossification demonstrated on the X-ray, but here's a CAT scan of the telangiectatic osteosarcoma. You can see where it's almost a moth-eaten appearance of the bone in this location. There's some ossification or mineralization in the actual tumor, and there's destruction of the cortex. The periosteum is not intact around this entire soft tissue component. This is the area of probably the Codman's triangle, and the tumor permeating in this area. Here's an MRI of telangiectatic osteosarcoma, and it's important to note the fluid levels. So similar as we discussed with an aneurysmal bone cyst in the radiological aspects of musculoskeletal tumors, telangiectatic osteosarcomas undergo ABC type changes, where it hemorrhages into the cystic cavities and the blood products settle to the gravity dependent area of the cystic cavities and form these fluid levels. Here's an X-ray of a telangiectatic osteosarcoma of the proximal humerus. Permeative lytic tumor with an indistinct moth-eaten border down in this location. There's cortical destruction. It expands into the soft tissues with a large soft tissue mass, and there's really no ossification that you can see on the X-ray. The gross appearance of a telangiectatic osteosarcoma can mimic an aneurysmal bone cyst. There's a mixture of large cystic and spongy areas. Here's an example of a telangiectatic osteosarcoma of the proximal tibia. This is a gross specimen that was transected coronally. And you can see these cystic cavities here, of which there are many of them, and many of them in this section filled with blood. So microscopic pathology, this is a low power view. You can't definitively tell that this is malignant on this low power view or that it's a telangiectatic osteosarcoma. But what you do see are these large cystic cavities filled with blood, and there's these thin septa in between the separating the cavities. This is higher power view, where you can see the walls of the septa, and you can see these malignant spindle cells. Normally cells do not look like this. They do not have these large, bizarre nuclei. The cells or the nuclei are different sizes and shape. There's pleomorphism, there's mitotic figures, and then in the wall of the septae there's ossification going on, or there's osteoid production. Okay, it's very scant osteoid production, but there is osteoid production. This should cinch the diagnosis of a telangiectatic osteosarcoma. Here's a high power view of a telangiectatic osteosarcoma. Very bizarre, malignant appearing spindle cells, large nuclei, pleomorphism. And cystic blood-filled cavities. The differential diagnosis of a conventional osteosarcoma, differential diagnosis of a telangiectatic osteosarcoma is a conventional osteosarcoma with dilated vascular spaces and an aneurysmal bone cyst. This is an example of an aneurysmal bone cyst. Here is an X-ray, and you see a fairly well circumscribed lesion, sharp zone of transition between the tumor and adjacent bone. The bone is expanded, however there's an eggshell rim of calcification around the expanded component. And on the MRI you see fluid levels, but you see a relatively well circumscribed lesion. Okay, with a sharp zone of transition between the tumor and adjacent bone. There's no permeation into the normal bone, and there does not appear to be any moth-eaten appearance. There's no Codman's triangle. This is the microscopic pathology of an ABC. You can see a large cystic cavity filled with blood in an ABC and a very thickened septa. Often there are giant cell tumors in the wall of an ABC. Giant cells in the wall of an ABC, and a fibrous type tissue. However, all the cells here look much more uniform. They do not look large, bizarre, or giant, or atypical. There could be some reactive bone production in an aneurysmal bone cyst, but it's reactive in nature. It's not produced by malignant appearing spindle cells, and when you see these osteoblasts are within the osteoid, it's indicative that it's benign appearing. These cells line up along the osteoid referred to as osteoblastic rimming. It's not scant lace-like laid down in between bizarre appearing cells. These cells, if you look here, all look very uniform in nature, and they're of the appropriate size, they're not crowded, and they're spaced adequately from each other. The biologic behavior of a telangiectatic osteosarcoma is similar to a conventional osteosarcoma. It's a fast-growing tumor, rapidly dividing, high grade with a high risk for metastases. Metastases are the same as that for a conventional osteosarcoma, the lungs being the most common site and the bones being the second most common site. So in workup of these patients, naturally of any osteosarcoma, a CAT scan of the chest and a whole body bone scan is important for staging the patient. The treatment for a telangiectatic osteosarcoma is the same as that for a conventional osteosarcoma. The same chemotherapy regimen is used, and it includes preoperative chemotherapy, surgery, and postoperative chemotherapy, or neoadjuvant chemotherapy, surgery, postoperative chemotherapy, or adjuvant chemotherapy. Prognosis is similar to a conventional osteosarcoma. Overall, there's a 65% 5-year survival rate. Low-grade intramedullary osteosarcoma is a low-grade form or a well-differentiated form of an intramedullary osteosarcoma. It's a low-grade fibroblastic osteoid-producing lesion, similar to Parosteal osteosarcoma, which is a low-grade fibroblastic osteoid-producing lesion on the surface of the bone. However, this arises within the medullary space of the bone. It's well differentiated, and it constitutes about 1% of all osteosarcomas. It's exceedingly rare. Patients will often present with signs with pain in the affected region for months to years. The peak age is in their 20s. 50% of cases occur in patients who are in their 20s. There are some cases between 10 and 20 years of age or in the second decade of life and in their 50s. The metaphysis of the femur and the tibia are the two most common sites. Radiographically, the tumor is usually metaepiphyseal. It often occurs centrally within the bone with ossification and sclerosis with expansile remodeling. It can appear like a ground glass density with internal trabeculation that simulates fibrous dysplasia. Usually there's no soft tissue mass, and it's not as aggressive appearing as a conventional osteosarcoma, and usually there's no periosteal reaction. Microscopically, remember, it's a fibroblastic tumor. It's going to look like fibrous tissue. Fibrous dysplasia can look very similar to this, that's producing bone, and here's the bone that it's producing. The bone usually has small cells in lacunae or small osteocytes within it, and it's this fibroblastic tissue that's producing the bone. There's no osteoblastic rimming. This is a higher power view demonstrating the osteoid production or the bone, immature woven bone production, and the fibroblastic tissue. High power view of the fibroblastic tissue. There's relatively bland looking cells. The cells are very similar in size and shape. It is hypercellular in nature. There may be some mitotic figures scattered throughout here, and there is bone production. There is no osteoblastic rimming. Treatment is surgical resection and reconstruction. There is no chemotherapy or radiation unless chemotherapy may be indicated if a component of it has dedifferentiated or become high grade, but in general, no chemotherapy for low grade tumors. In addition, just to make a note, really virtually radiation is not included in the treatment armamentarium for osteosarcomas, unless perhaps it's a huge pelvic tumor and there's a positive margin, but in most cases radiation is not used in the treatment of osteosarcomas. Prognosis is a 90% cure rate or less than 10% metastatic rate with surgical resection alone of a low-grade intraosseous osteosarcoma, and as long as it's entirely low-grade and there are no areas of dedifferentiation. Okay, now we're going to talk about our surface or juxtacortical osteosarcomas. Our three types of surface osteosarcomas include parosteal osteosarcoma, periosteal osteosarcoma, and high-grade surface osteosarcoma. Parosteal is the most common. It arises from the outer layer of the periosteum. Periosteal, it arises from the inner layer of the periosteum. It's primarily a chondroblastic tumor. And high-grade surface osteosarcoma, which is the most rare type of surface osteosarcoma, resembles histologically that of a conventional osteosarcoma. Okay, let's start with talking about parosteal osteosarcoma. A parosteal osteosarcoma is a low-grade, well-differentiated fibroblastic tumor, meaning that there's fibrous tissue that you're going to see that produces bone or osteoid or immature woven bone. It comes from the outer layer of the periosteum, hence it compresses the periosteum up against the bone. It does not elevate it. You will not see a periosteal reaction with it. It is slow growing and slow to metastasize and infrequently metastasizes. It's the most common type of juxtacortical or surface osteosarcoma. It constitutes 5% of all types of osteosarcomas. Dedifferentiation refers to a portion of the tumor changing and becoming a high-grade type of sarcoma, and this may happen with long-standing tumors. Parosteal osteosarcomas that are present for a prolonged period of time may invade the bone, the medullary canal that it arose from, and typically these tumors that grow into or through the bone and into the medullary canal have higher grade areas within them, or they've been around for a prolonged period of time. Parosteal osteosarcomas usually present as a painless, slowly enlarging, firm, immobile mass in an extremity. Develops twice as often in females as in males. It usually affects a 20 to 40 age group, whereas conventional osteosarcoma and the majority of other osteosarcomas affect ages between 10 and 20 years. Sites. The posterior distal femur metaphysis is the most common site, with 65% of cases occurring in that location, and it presents as a mass of the popliteal fossa with perhaps decreased range of motion of the knee. The proximal humerus, tibia, and the fibula are the next three most common sites. Here's an X-ray of the distal femur. There's a lobulated and ossified exophytic mass that's cauliflower-like that you can see here on the posterior aspect of the distal femur. The cortex appears on this X-ray to be intact. There's no medullary continuity with this, so it's not an osteochondroma. It has radiodensities throughout it as well as radiolucencies. The radiolucencies peripherally usually represent low-grade cartilaginous lobules, fibrous tissue, or fat. There's no periosteal reaction because it compresses the periosteum. And there may be a string sign that may not be picked up on this, but may be picked up on a CAT scan. At the periphery, There's a cleft between the exophytic base and the cortex at the periphery. It's often only identifiable on the CAT scan. Here's another example of a parosteal osteosarcoma of the distal femur. It's exophytic mass arising from the surface of the bone. This one is heavily ossified. The cortex appears intact along the deep surface of the lesion. Very worrisome tumor. Here's a CAT scan where you can CAT scan of a parosteal osteosarcoma. You can see here the cleft, the cortex here. There is perhaps some back growth of the tumor into the medullary canal, and there's some lucencies admixed with radiodensities. These lucencies are more identifiable on the CAT scan than they are on the X-ray. Here's a parosteal osteosarcoma of the proximal humerus. It's heavily ossified. It's an exophytic mass arising from the surface of the humerus. Here's what the MRI of the same tumor appears. It's an exophytic mass. There's some back growth into the medullary canal of the humerus. Here's a CAT scan of the proximal humerus parosteal osteosarcoma. You can see this exophytic mass. There's radiodensities as well as some more radiolucent areas. There's back growth here into the medullary canal of the humerus. There's medullary canal invasion. And there's the cleft over here and a cleft over here, where kind of an invagination between the exophytic portion and the actual bone. Here's a plain X-ray and a CAT scan of a parosteal osteosarcoma of the distal posterior femur. Again, a large exophytic mass, heavy mineralization, but also areas where there are non-mineralization. There's a very large area here that's non-mineralized on the CAT scan. Perhaps it's an area of dedifferentiation or a higher grade area. They may represent cartilaginous components or fibrous tissue components also here. And there's a cleft right here and a cleft right here. Okay, and it's starting to grow around the surface of the femur. Perhaps some back invasion into the medullary canal. This is a very large tumor. Okay, this is the gross pathology of a parosteal osteosarcoma. You can see the firm exophytic bony mass fixed to the cortex. The underlying cortex appears to be intact. There's a broad base, and it may encircle the bone or may invade the medullary canal. This specimen does not, however. This is the microscopic pathology for a parosteal osteosarcoma. It's very similar to a low-grade intraosseous osteosarcoma. You see islands of immature trabeculae of woven bone admixed in fibrous tissue. So there are spindle cells in here producing this fibrous type tissue. So there's a sea of fibrous tissue with these islands of immature woven bone. There is no osteoblastic lining of the trabeculae, and the fibroblastic tissue is bland. It's hypocellular. There's minimal pleomorphism. There's minimal mitotic figures. Showing a higher power view of the fibroblastic stroma and the immature woven bone. We recognize this as bone and fibrous tissue. They're trying to form immature trabeculae. And how this differs from our osteoid osteoma, there's a very rich fibrovascular component, and the trabeculae all intervene and touch each other, and there's osteoblastic rimming on in an osteoblastoma. Right? These would be lined with plump osteoblasts, and there'd be a lot of blood vessels and fibrous tissue in the intervening stroma. The treatment is wide surgical resection and reconstruction. Chemotherapy and radiation are not indicated. The only time you would consider chemotherapy is if it dedifferentiated or if there was a high-grade component in the specimen upon complete evaluation. Prognosis: there's an 80 to 90% cure rate for low-grade parosteal osteosarcomas treated with surgery alone. Metastases do occur, but they are more common if there is medullary invasion seen, if there are any high-grade grade 3 components in the tumor, or if there's dedifferentiation that occurred, or grade 3 components in the tumor. Again, this is an example of a parosteal osteosarcoma versus an osteoma. You should see the difference. An osteoma blends imperceptibly with the cortex and looks like an exophytic mass. There's no clefts here, and it's very uniform, solid and uniform in appearance. The parosteal osteosarcoma looks cauliflower-like. It's exophytic. There may be clefts that you can detect on a CT, and it's not as radiodense as an osteoma, and there are some radiolucent areas, and it's very undulated. The cortex does appear to be intact deep to the mass. This is the difference between a parosteal osteosarcoma and an osteoma. You can see the mature haversian systems around the haversian canals, laid in a concentric manner, very mature and organized. This is fibrous tissue with islands of immature woven bone or trabeculae being produced by the islands of fibrous tissue. There's no osteoblastic rimming. So parosteal osteosarcoma versus an osteochondroma. On the osteochondroma, you can see where the medullary canal and the cortices are continuous with the osteochondroma. Then here's the cartilaginous cap of the osteochondroma with calcifications in a ring and arc-like manner. And again, the parosteal osteosarcoma is an exophytic mass applied to the surface bone. The cortex is intact. There's no corticomedullary continuity. Again, this is an MRI of the osteochondroma where you see the cortex expand and the medullary canal expand into the osteochondroma. Periosteal osteosarcoma is the next entity that we're going to talk about. It's a second most common type of juxtaarticular or surface osteosarcoma, and it is an intermediate grade tumor that is a chondroblastic tumor. It's not a fibroblastic, it's a chondroblastic tumor, much different than your conventional osteosarcoma or your parosteal osteosarcoma. A periosteal osteosarcoma constitutes less than 2% of all osteosarcomas. It's very rare. Periosteal osteosarcoma arises from the inner layer of the periosteum and therefore elevates the periosteum and produces a periosteal reaction. It's a chondroblastic tumor that produces osteoid or bone. Sometimes because of the significant chondroblastic component, it can be barely detectable on an X-ray. The diaphysis of the tibia is the most common site of origin. It's considered an intermediate grade tumor as compared to a conventional osteosarcomas that are high grade. It has a better prognosis than a conventional osteosarcoma. However, it's treated almost identically as a conventional osteosarcoma. Most patients are between 10 and 20 years of age. The most common sites are the surface of the tibia, the diaphysis of the tibia, and the diaphysis of the femur. They constitute greater than 85% of cases. The humerus, the radius, and ulna are also common sites. Plain X-ray shows a diaphyseal lesion on the external surface of the bone. Medullary canal is usually not involved. It's usually primarily radiolucent because of the chondroblastic nature. The cortex may be saucerized or slightly eroded or scalloped. And you often have a periosteal reaction, hair on end or sunburst periosteal reaction, because a tumor arises from the inner layer and elevates the periosteum, and you can see that in this example. There may be partial matrix mineralization that is seen, and there's rarely intramedullary invasion. This is showing you a closer view on an X-ray. This is primarily a radiolucent lesion on the surface of the tibia with a hair-on-end periosteal reaction. If you see this periosteal reaction, it is very worrisome for a malignancy. Here's an X-ray of a periosteal osteosarcoma of the proximal tibia. Again, a surface lesion with hair-on-end periosteal reaction, primarily radiolucent or chondroblastic. There's some subtle suturization or erosion of the underlying cortex of the bone. This is an MRI of the same periosteal osteosarcoma of the tibia. There's mild suturization of the underlying cortex. There's a large mass. There's no intramedullary invasion. It's primarily high signal on T2 weighted images, which is consistent with a cartilaginous type tumor or a chondroblastic tumor. Again, in the MRI of periosteal osteosarcoma of the tibia, again, T1 intermediate signal with heterogeneous in nature. It's applied to the surface of the bone. It's scalloping the surface, very high signal on T2. Here's a CAT scan of a periosteal osteosarcoma of the tibia, where you see the periosteal reaction or the hair-on-end periosteal reaction and perhaps some mineralization within the tumor. Microscopic pathology demonstrates a chondroblastic tumor. You can see here lobules of poorly differentiated cartilage. There's hypercellularity. The cells are different sizes and shapes. There's sometimes multinucleated cells. There's perhaps some mitotic figures. And these lobules of cartilage are separated by malignant appearing spindle cells, which you can see over here on this portion of this slide. Hypercellular spindle cell area. And the osteoid production usually occurs in the spindle cell area of the tumor. It's deposited in a lace-like manner in between the malignant spindle cells. Here's an example where it shows the osteoid production by the spindle cells. Here's the spindle cells in this area here, and osteoid production. Here's some osteoid production, which is pink and lace-like, and cartilaginous-like cells in lacunae. Periosteal osteosarcomas have a 15% metastatic rate. Most of them metastasize primarily to the lungs. Treatment usually includes preoperative and postoperative chemotherapy and surgery, although the benefit of chemotherapy is controversial. The prognosis of a periosteal osteosarcoma, there's a 15 to 25% metastatic rate to the lungs, or an 85 to 90% 5-year survival rate. Survival is much better than a conventional osteosarcoma, and there's a much lower metastatic rate. High-grade surface osteosarcomas are the least common surface type of osteosarcoma, or least common juxtacortical type of osteosarcoma. Histologically, it looks exactly the same as a conventional osteosarcoma, except that it occurs on the surface of the bone. It's a type of high-grade osteosarcoma that develops on the surface of the bone from the outer cortex. It does not develop from the periosteum. There is no to minimal medullary involvement. Microscopic pathology is the same as a conventional osteosarcoma. It has a high potential for metastasizing. It's the least common type of surface osteosarcoma, and it's very rare. It constitutes less than 1% of all osteosarcomas. The femur is the most common site, followed by the humerus and the fibula. The diaphysis or the metadiaphysis of the bone is the most common site of origin. This is a plain X-ray of a high-grade surface osteosarcoma of the distal tibia. You can see subtle cortical erosion, very large soft tissue mass with ossification in the soft tissue component. This is gross pathology of a high-grade surface osteosarcoma of the distal tibia. You can see this is the case from the previous X-ray, the subtle areas of cortical erosion, very large mass with significant necrotic cavity. When these tumors grow rapidly, they cut off their own blood supply and cause necrosis. And the tumors are rising from the surface of the distal femur, and here's a fleshy area of the tumor. The microscopic pathology is the same as that of a conventional osteosarcoma. The lack of medullary involvement distinguishes this tumor from a conventional intramedullary osteosarcoma. It consists of a high-grade anaplastic pleomorphic spindle cells producing osteoid, an immature bone that is deposited in a lace-like manner. And you can see here the bizarre appearing hyperchromatic pleomorphic cells producing osteoid, all this interlacing lace-like osteoid being laid down. There's no osteoblastic rimming, and it's not being laid down like a trabeculae. The treatment is the same as that of a conventional osteosarcoma, including preoperative chemo, surgery, postoperative chemo. The chemotherapy is the exact same regimen, and the survival is similar to a conventional osteosarcoma. Intracortical osteosarcomas are exceedingly rare tumors. An intracortical osteosarcoma is an extremely rare type of high-grade osteosarcoma that arises within and is usually confined to the cortex of the bone. Differential includes an osteoid osteoma, a bone abscess, a non-ossifying fibroma, osteoblastoma, and adamantinoma. Clinical presentation of intracorticals usually is between 10 to 30 years of age. Most common site is the diaphysis of the femur or the tibia. Plain radiographs show intracortical irregular lytic lesion with surrounding sclerosis. The junction of the lesion with the normal bone is usually irregular but may be sharply demarcated. There's usually permeation of the cortex. Lesion may demonstrate ossification or mineralization, as you can see in this location, and there's minimal to no periosteal reaction. This is an MRI of an intracortical osteosarcoma. It's an intracortical tumor with surrounding edema. It almost has an appearance similar to an osteoid osteoma, except it's much more permeative in the cortex than an osteoid osteoma. This is the gross pathology of an intracortical osteosarcoma. It's a fairly well-defined tumor, has irregular borders, and the tumor can be gray, tan, yellow, and gritty for mineralized osteoid production. There's necrosis here also, indicative of its high-grade nature. So expanded cortex, necrosis and hemorrhage, intracortical tumor, and permeation through the bone. You see over here where it's permeated and almost like causing a moth-eaten pattern, which is a sign of malignancy. This is a microscopic pathology. Again, looks identical to a high-grade osteosarcoma. Spindle cell tumor where there's hypercellularity, pleomorphism, hyperchromatic nuclei, mitotic figures. Cells are crowded and haphazard. The osteoid is laid down in a lace-like manner in between the malignant cells. The differential diagnosis of an intracortical osteosarcoma is osteoid osteoma, Brody's abscess, osteoblastoma, non-ossifying fibroma, eosinophilic granuloma, osteofibrous dysplasia, and adamantinoma. Treatment is en-bloc resection, limb-sparing surgery whenever feasible, and efficacy of chemotherapy is uncertain given the small number of cases, but would be treated the same as a conventional osteosarcoma. I'd like to thank you for listening to this lecture. I hope it's provided you with some important information and that it helps you on your OIT exam or your certification exams. One thing to note is that while osteosarcomas most commonly arise from the bone, there is a soft tissue osteosarcoma, and just as though osteosarcomas can arise from the bone, you can have a soft tissue sarcoma that produces bone in the soft tissues. It's much less common, and it occurs in adults. It's not one of the most common types of soft tissue sarcomas, but it's very possible, and we will talk more on that in our soft tissue tumor lectures. For more information on sarcomas and musculoskeletal tumors, please visit my website at www.tumorsurgery.org. Thank you.